Fantastic. I can see people joining us. So my name's Irene Higginson. I'm the director of the Better Health and Care Hub. So I'm going to talk through the what, the why, and the how, except we don't quite know all the how yet, of the Better Health and Care Hub. With our goal really of co-creating and then evaluating and then disseminating better health and care futures for those who have complex needs. And the sort of areas that I'm going to cover are the challenges facing health and care. Just a brief overview. I know that Annette and Anne-Marie are going to pick up some of those a little bit later. Why we're focusing on complexity and why we think an interdisciplinary approach is necessary, what the Better Health and Care Hub actually is, the themes and innovations we have within it, what are the opportunities for impact, and then I hope that we'll get into a wider discussion of how to get involved, the partners and the priorities. So I think we all know that health and care is in challenge around the world. And they struggle with rising costs, workforce shortages, and much more. And in fact, the challenges have often been outlined in this sort of major circle of challenges that I'm outlining there, which really takes you through the issues of the challenges around aging populations, around increasing multiple long-term conditions, around patient experience, about mental health, around the costs, around the emergency department use, and around the primary and social care use. And if you think about this, in fact, the health and care landscape is changing and has been changing. So around 2/3 of those people over 65 are expected to be living with multimorbidity by 2035. Healthcare spending is increasing as a percentage of gross domestic product, and it's been rising over the last 20 years. And yet all countries are facing fiscal challenges and uncertainty. There's also the question around climate change and the role of healthcare contributions in that. And the area that solutions are most frequently overlooked is for complex people who are the highest cost and the poorest outcome. And quite often people with multiple long-term conditions leave hospital more ill than when they enter. Inequity is widening. So, for example, emergency attendance in areas that are socially deprived is double. There are workforce shortages and there are population challenges that are in existence. So if we come into just a little bit on the health and care workforce shortages, then a World Health Organization report into the state of the world's nursing in 2020 showed a global problem in nursing shortages. Workforce shortages strain the health and care systems, leading to overburdened staff who don't want to carry on working in healthcare, longer wait times, reduced care quality. And in fact, adequate staffing is crucial for availability, accessibility, and effectiveness of services. And actually, shortages lead to an increase in costs because of either inefficiencies, misdiagnosis, or the need to bring in agency workers who cost a lot more. The NHS long-term workforce plan in healthcare expects a shortfall of between 260,000 to 360,000 healthcare staff by 2036 or 7. And if you look across vacancies currently, you can see that there are around 125,000 vacancies in hospital and community health services. And over 1 in 10 nursing posts are unfilled, and there's also a shortage of doctors. And I know that Anne-Marie and Annette are going to talk more about the workforce shortages in social care, which is important to note. And the shortages are increasing. So this is some data from the European Commission actually met in Strasbourg in February this year to discuss this, and the fact that the World Health Organization expects a shortage across the European Union of 4.1 million health workers. And in fact, in January, the EC launched an action to support states in retaining and attracting nurses with programs such as mentoring, digital transformation, and analysing structural shortages. And you can see in the graph how the job vacancy rate has changed in health and social care across the European Union. The UK is not included in these data, but you can see that with increases very high in parts of Europe. Now, why do we focus on complexity? I think is because, in a way, complexity is where health and social care is needed most, and has a major impact, and yet is often neglected. What do we mean by complexity? So I'm very grateful to Lorna Fraser and colleagues for this figure, where they produced an analysis of what complexity is. I think I saw Lorna on the webinar, so any difficult questions about that can go to her. It involves looking at chronic conditions, health and social care use, functional limitations, and the wider social and support needs in care. And linked to this is multimorbidity is rising at all ages, and aging is increasing. And you can see there that how even if you stratify multiple morbidity by age, you can see that it exists in people at all ages, but it is higher often in older age groups. You can see how it's increasing over time, with the green area, the percent of people with 3 or more conditions increasing by about 30% over the period covered, and how you can see how worldwide the projections are that it's going to increase even more in people at all age groups. So as I mentioned at the beginning, chronic and multiple conditions are already common, but they'll be about 50% of the population by 2035, and they'll be higher. There'll be a percentage who actually have 4 or more things. And if you think about informal carers, or unpaid care, as some people call it, then Carers UK estimate that about 5.7 million people in the UK provided unpaid care in 2021, which actually was the whole value of the NHS system. So we need to think more carefully about how caregivers are engaged and involved. There's also an issue around involving volunteers, which are increasingly involved in the healthcare system. And then inequity is a particular challenge for people with complex illness, because people with complex illness are disproportionately highly found in people with complexity. So the Better Health and Care Hub, what are we doing, is trying to forge and sustain better health and care futures for those with the most complex needs. And the way that it's organised across the hub is that it brings together all the different faculties of King's College London and wider partners to benefit the populations that I've outlined, which are shown again on the left-hand side, and to have impact, which you can see along the right-hand side, around global, national and local impact. And it is focused around 3 main themes, which we'll talk through shortly, and with a number of activities. So the activities, what are the activities? Are 4 connecting activities, one around research delivery, one around policy influence, and in that we're partnering with the King's Policy Institute, one around consultancy services, which are not done yet, but we will be developing, and one around educational offers with a new MSc programme starting next year in healthcare management. We have some other plans as well underway. So what do we mean by these clusters that we've talked about? Care force, frugal innovation and communities. So what we want to do in a way is having a paradigm shift, really, fostering the idea of a care force which recognises that everybody is involved in delivering care, including the person's self-management and the informal support. I've highlighted how common it is for unpaid carers and from volunteers. And we also want to, in addition to expanding this understanding of the traditional workforce, we want to take a really active account of those really critical roles of nurses, midwives, allied health professionals, plus volunteers and social care professionals. So we want to take account of the professionals, but also that are so acutely stressed and stretched at the moment, as well as expanding the traditional definition of what the healthcare workforce is. In frugal innovation, we're trying to rethink technology for accessible and equitable care. So we want cost-effective solutions that optimize resources and improve access while maintaining quality, and in particular are focused on supporting people in their own homes. So a couple of case studies to give you some examples of our thinking here is this is a 12-week digital intensive care recovery pathway that was developed by Professor Louise Rose, a professor in our faculty, and a number of others, developing a TouchAway app that enabled a focus on personalised recovery goals for people who were being discharged home. And then there's new work now trying to engineer a simple handheld motion sensor squeeze ball to inform community rehabilitation. And I think this is important because while many industries have really tried hard to leverage frugal innovation to improve the back office functions and increase automation, health and care have lagged behind. And in fact, one of the biggest drivers for the increase in healthcare costs is very expensive new medicines and very expensive new technologies or other therapies. And I think we turn it on its head by trying to think, well, what can we do that's frugal? And I'm really keen that we might work with some engineers to think of how do we do frugal innovation in the community. And just to give you another example of frugal innovation, or rather a couple more examples of frugal innovation, then we've also got some work on people with serious breathlessness and serious illness. Very large number of people worldwide, 2 million at least in the UK. And we developed an integrated service, which was a combination of frugal self-management, targeted support, which actually improves quality of life at potentially lower healthcare costs with the saving of around £50,000 per patient due to being able to prevent the sort of emergency bouncing in and out of hospital. I think there's also opportunities nowadays for a much better use of existing data sets and evaluation using those data sets. And then in terms of co-partnering with communities, so communities, what we're thinking here is of co-production and partnering with patients and communities. And these communities are really central to our approach, and health solutions work best when they are co-produced with communities, and they're more likely to be sustained that way. And this is the advert for the next webinar, because Professor Glenn Robert in the next webinar, which I think is on the 5th of June, will be actually dealing with this topic. But just other things that we've done with communities is an interesting public engagement departure lounge activity, which actually went round shopping centres to actually discuss end-of-life care and what people would like, done with the Academy of Medical Sciences. If you want to read more about this, we have an article in the New England Journal of Medicine Catalyst, and hopefully one of my colleagues will put a link to that in the chat. Now, how are we going to create impact? That's very important. There isn't time to go into all the details about this. We're thinking very carefully about the knowledge mobilization that we need to do, but we're thinking that impact will be important locally, and we hope to work jointly with partners locally to develop local demonstration cases. We aim to have multi-site programs nationally to ensure generalizability and scale. And many of the issues are not only based in the UK, so we're very interested in the global activity and relevance of activities that we can do, including with South-North learning and North-South learn, as well as North-South learning, and also East-West learning, as well as West-East learning. Another important strand to what we're doing is thinking about the development of inclusive methods and better methods of co-production to improve our approach. Now, these methods will run across all of our research theme areas, so care, force, frugal innovation and communities, pioneering how the research is done and working with diverse communities. I think there are other things that we're keen to develop the methods for, including things like simulation in education and how can that be developed to improve the situation of the workforce. So the Better Health and Care Hub is committed to creating a future where care systems are inclusive, sustainable and responsive to community needs. And by leveraging this focused area on these three areas, I hope you understand why we're focusing on these. They are interconnected. I don't think you can do frugal innovation without thinking of the care force and the communities. I don't think you can do communities without thinking what, which is about the care force and frugal innovation. And I don't think you can do, so they will all depend on each other. But by leathering strengths in these areas, we hope very much to work with others to forge a better health and care future for everyone who needs it. And I am hopeful that many of you might join us and partner with us in the future of health and care. I'm keen to know how this initiative can help you and what you do and make your work more competitive. I think that's all I want to say. I think the best way to go, because I am very nicely spot on time. So I think I'm going to hand over to Annette and Anne-Marie, Annette Boaz and Anne-Marie Towers, who are also going to present, and that's so clever. They've chucked me off the sharing, which is brilliant. They are from the Health and Social Care Research Unit, and Annette is also a co-director in Better Health and Care Futures. So Annette, over to you, and thank you.
Thanks, Irene, and hopefully lots of threads that we're going to pick up in the presentation. I'm sure you've got lots of questions and things to raise, Irene. I think that was a really good, we are really keen to think about how we can connect this work, so please start thinking about that, and there'll be plenty of time. We're going to be quick, aren't we, Anne-Marie? So there's plenty of time for hearing from you. So thanks for the invitation to talk about the work that we do in the Health and Social Care Workforce Research Unit. This is one of the Department of Health and Social Care's 20 policy research units, but we also have a wider programme of work, and this is an opportunity for us to tell you a little bit about that work, how we see it connecting with the hub, but also I think there are many opportunities to connect the work we're doing with others in King's and more widely. So it's an opportunity also hopefully to see some connections, and please do get in touch if there are things you think you would like to talk to Anne-Marie and I about. So what we're going to try and do in this presentation is talk a little bit about the work that we do and how that might connect with the work the Hub's going to do to really think about advancing research that addresses real world challenges. And in our case, we're going to focus today on the work we do in social care, although I will bring in a couple of examples from the work we also do in health. And also to think about work Anne-Marie and I are really kind of passionate about, which is thinking a bit about how we work differently as researchers with the care providing sector, with other researchers and with communities. So that's what we're going to work through today. So Anne-Marie's going to start off by giving a bit of orientation to the challenges facing the social care sector in case many of you come from health, and this is something that will help with what we're going to talk about.
Brilliant, thanks Annette. Yes, hi everyone. So actually, when we put these slides together, it was really clear how nicely it mapped across to the themes that Irene has introduced already this morning for this programme of work. So I'll give you a whistle-stop tour, building on the notes that Irene's already given, which all apply to social care just as they do to health. So first of all, one of the key challenges facing the sector at the moment is around the workforce. So some of you may be aware that turnover and vacancy rates are very high. This is across social care and social work, but also allied health professions working in social care settings such as local authorities. And these, as well as having direct implications for the quality of care and the outcomes of people drawing on care and support, it also taps into questions around continuity of care, but also data consistency. So how we're collecting data about people, who's completing those data fields, and how we're sharing that data. In terms of the workforce, we know from surveys and lots of research that's been undertaken that they feel they have limited time and capacity to engage in or support research. And I'll talk later towards the end of our slides about how we are addressing this through innovative ways of working with the sector. There are also considerable skills gaps around research literacy across the sector, especially in non-academic settings. And all of these things just make working with the sector and undertaking research in a timely way more challenging than it is in conventional healthcare settings, where people have the infrastructure, the knowledge and the experience of undertaking research. So there's a real need for innovation in the sector. At the moment, service models lag behind evolving service user needs and the digital possibilities. So we heard some really good examples of some innovations there within the health sector, and that's what we're looking to encourage and evaluate within social care as well. How can we better make use of digital and tech to take the strain off of the care force and deliver better outcomes for people drawing on care and support? There's been insufficient investment in testing and scaling new technologies and approaches to date. And even when there is good evidence, or at least some preliminary evidence, that technologies may be effective and may be helpful, what we often find is that research fails to translate these into real-world practice. And that's partly around the points that I made above about that kind of lack of research engagement and awareness, but also around lack of support for implementation and needing a much stronger infrastructure to support implementation and research in social care settings. And finally, moving on to the theme of communities, one of our challenges when trying to work across social care is the fragmented nature of the system. This includes the relatively poor integration between health, social care, housing and the voluntary sectors, which, as you can imagine, really hinders the kind of holistic research that we're aiming to do. So there's something really important here about how we bring these different systems and communities together to really make a step change. But also, as I mentioned earlier, there's something here around data. Often what we find is that data is being held by different parts of the system in different places, and they're not adequate data sharing agreements or access even amongst clinicians and practitioners who would gain valuable insight from being able to collaborate and share things like patient records with one another. So there's a lot of work that needs to be done around that. And finally, although we've made a lot of headway with this recently, community voices, especially from marginalised groups, remain underrepresented in shaping research agendas. And this is another challenge that we are hoping to address as part of our ongoing and future work.
Thanks, Anne-Marie. So this idea of kind of the workforce and care force is really useful for us and have been really helping us with the thinking we do as a workforce research unit. And I was just going to highlight some of the types of work that we do. So our program is set 80% by a kind of 2.5-year project. So we have 2 sets of those over 5 years. And we also do more responsive work where policy teams bring project ideas to us, and we do those in quite a rapid sort of 6-month period. So to respond to kind of time critical policy ideas. So at the moment, for example, we've got a piece of work going on looking at the implementation of apprenticeship schemes. So particular focus of that has been looking at apprenticeship funds. So how resourcing is put in place to incentivize people to do social work apprenticeships, for example. We have a project looking at how you support career development in adult social care, and this has such a wide remit. It incorporates things like the pay agreement for the sector, but also how we ensure people feel they're being valued and how we build kind of infrastructure for them to get the skills they need. As Anne-Marie was saying, this is considered to be a big gap in the adult social care sector. We have got a project at the moment where we're looking at new roles. So we're looking at how roles within the health and social care system that help people navigate and work across the gaps between health and social care. And this is particularly targeted for people with complex conditions, and how these kind of particular roles have been introduced that help people to navigate their complex journey through the system. And actually some of the difficulties people have within those roles, they're often quite vulnerable roles in the kind of overall system. And as changes go on in the integrated care system, we worry that these roles in particular will be very vulnerable because they maybe don't have those kind of very concrete and measurable outcomes in terms of benefits, but are doing all kinds of kind of very nuanced navigating. And one example that came up through that study was about somebody, one of these care coordinators had walked with someone, the walk from their house to their grandchild's school after recovering from an illness and an operation, had gone and done that walk with them. And what showing somebody that they could do that and they'd be able to take up that role had major implications for the family in terms of her daughter being able to go back to work. So the complexity of the jobs and that are needed to help people really thrive even when living with long-term conditions, I think is a really interesting part of workforce roles. We're also doing some work on looking at recruitment retention, so looking at how we keep hold of people within the workforce, what it is that's making it difficult for them to stay, and we're particularly doing this through a survey that's been done of the social care workforce, but also other projects that are interviewing people and talking about recruitment and retention. We've got a project going on at the moment looking at international recruitment, so looking at the International Recruitment Fund, so evaluating how that's been implemented in social care, and we're doing some follow-up work on the social care workforce survey that's just come out. So we've got all kinds of projects going on in social care. And also work in health, a couple of projects I wanted to mention. One has been looking at the role of volunteers. So we have a bigger piece of work going on in the unit on volunteers, but we have a specific project where we've been looking at community first responders. It's been so interesting seeing the role those volunteers play, going out ahead of the ambulance service. And the word that comes up over and over again is reassurance. People seeing such a critical role, reassuring people, helping them understand what's going to happen when, why they're waiting, if they're waiting, escalating where they see problems, and giving people somebody to kind of talk to and to listen to them at a very, very stressful time in people's lives when they've called an ambulance. So that's a really interesting piece of work we're doing at the moment, looking particularly at those kind of community first responders. And we have other projects going on in health. So for example, we have a project looking at widening participation in the NHS, and that's not with a diversity and inclusion focus, but about thinking particularly about how the NHS might be a really good workforce to join for people who are coming from, for example, having been in the care system, in the prison service, who've come from all kinds of different backgrounds that make it hard for them to access the workforce. And we have a National Health Service in the UK that could be a potentially really rich environment for people to build skills and build careers, and also be, you know, in a kind of supportive work environment. So those are the kind of projects we do, and we're always looking to engage with people who have expertise in this area, because we're often picking up new projects at great speed. I just wanted to flag in terms of engagement that we've also started working. We have a really active public contributors group who really shape and challenge the work we do all the time. But we have a brand new workforce panel, all of them frontline workers in health and social care who are helping us with our research program. And that's a new initiative for us, but already really changing the way we do our research. Anne-Marie.
Thanks, Annette. So the other programme of work that we've got that really overlaps with this programme is the work that we're undertaking as part of the NIHR Applied Research Collaboration in South London. We are privileged to lead the social care theme for the ARC South London, and it's had a very successful programme of work, and we thought it would just be interesting to let you know a little bit more about one kind of case study that we're as an example of the work that we're doing to date. So this particular study that you can see on this slide is actually a study that started in October 2024, and it was designed to understand and investigate how social care can feed into the prevention narrative. It's called the Prevention Role of Social Care for Older People, Triggers, Judgment Calls and Processes, or the PROP study for short. So health and wellbeing monitoring is often routinely done by people working and volunteering in services. And the aim of this study is to find out what triggers staff and volunteers to act when they notice that something out of the ordinary is happening for somebody. So they've noticed that there might be an unmet need, there might be something that's changed around this person's context or health. What do they do next? We're going to be also finding out how useful this work is for people working elsewhere in the system. So how do these roles support the wider system? So what we're looking for is examples of small acts of care that workers and volunteers in different sectors often perform that prevent deterioration in health conditions, improve quality of life, and to really get a better understanding of how these happen. So as you can see from this, there's going to be a focus on 3 different groups. There's home care workers, services that are often, we're calling it, on the margins of social care, such as lunch clubs, and also voluntary sector or community services such as befriending, bereavement and support. So all kinds of aspects of that wider community that Irene and Annette have already mentioned. So this study will run until the end of the ARC, which is March 2026, and we're currently recruiting participants to interviews and focus groups in those 3 boxes now. So no results to share, but if you would like to keep up to date with this, there is a link at the bottom left of the screen there for you to find out more.
Thanks, Anne-Marie. And we just wanted to mention the kind of wider work that our colleagues do in the Health and Social Care Workforce Research Unit. So most of the work we've been describing today has been around workforce, but we also do a lot of work which is really focused on people with complex needs. And these are a set of animations, and we're going to put a link in the chat if anyone would like to look at these, that were done at the end of a set of studies done as part of the NIHR School for Social Care research programme. And they're really kind of nuanced. I think these give us an opportunity to look into studies done in really complex areas. So the first is this idea of dementia champions. So this was a kind of role people could apply for to really speak out for the importance of looking after people with dementia and working in the field. And so this is a really nice animation around actually what it means for people to take on these kind of roles and what it means to support people living with dementia in their homes. And then there's a really lovely animation which is looking at kind of thinking about what it means to be a parent with learning disabilities and how services protect those people and can help them, and also how challenging it can be to be really supportive in this context. And then we have a program of work on homelessness, which I think we find really challenging in terms of just how complex the needs are of the people who participate in this work, and just how much there is to do to provide. So they're kind of, if you like, a kind of test case of just what it is to be looking after people with complex ongoing issues around their health and social care, really traumatic lived experience, and real connections through to some of the other work we do, for example, with children and families. So these are kind of just some of the examples of the other work we do in social care in the unit, where we really try to be brave about the kind of topics and areas that we explore.
Okay, so going to just end today by talking to you a little bit about something that Annette and I are quite passionate about, which is how we can work with partners to make sure that social care research is useful, usable and used. And we have some examples, and I will try and pop them in the Q&A, some links in there to the websites for those of you who want to see, to read about these a little bit more detail. But essentially, for the last 4 or 5 years, Annette and I have both been leading something called research practice partnerships. And these are partnerships between the social care sector, academics, universities and researchers, and also people with lived experience of social care themselves and or caring for those who have. So the reason that we think partnership working is so important is that essentially it bridges the gap between these different parts of the wider social care research community. And I think a key strength for them is that they enable us to ensure that research addresses real world priorities for the sector, but not, so it's kind of like if you imagine the research trajectory from the design of a study all the way through to trying to implement and share knowledge. Having a partnership from the very start means that the research questions can be driven by the priorities of the sector and for the sector, and they can be translated and implemented because those people who have already identified them as being important and relevant to their work or to their care can be involved at the end in evaluating them and then thinking about how they would implement them in practice. So there's a real strength in the design of these research practice partnerships to make a real step change. We also think that one of the hesitations people have around engaging with research is a lack of trust and a lack of understanding. And we've already talked at some detail about the fact that there's a lot of research capacity building that needs to happen in this sector. The advantage of this kind of research practice partnership is that you work together over a long period of time, and this allows us to foster that feeling of mutual learning, build trust, which again is essential for implementation and wider impact. So to give you some specific examples, over the last 5 years, we've been leading something called the Kent Research Partnership, which was co-led with Kent County Council and people with lived experience. And that particular research partnership is all about embedding research into practice, funding pracademics, so practitioner academics, to undertake things like research fellowships, leading communities of practice around research priorities for the sector, and generally trying to make a real step change in research culture in one local authority. Those papers are, that programme of work is being evaluated now, and the papers are in draft. So hopefully some of those findings will be coming out in 2026. Annette's been leading something called Creating Care Partnerships. And this is about supporting partnerships between universities and care homes in England. And the care homes are from 3 areas. So we've got Newcastle, Chester and Lancashire. And what's been really interesting about those particular partnerships is that unlike the Kent Research Partnership was one partnership at a local authority level, in Creating Care Partnerships, we've been able to experience what these different partnerships might look like depending on the relationships with the different care homes. So quite different models, but around the same theme, which is research capacity building and ensuring that priorities are set from the grassroots. I've already mentioned a lot about the work that we're doing in Arc South London, and I've included a link in the chat to that while Annette was talking. But as part of our additional investment in knowledge mobilisation, we are going to be doing creating a new research practice partnership focusing on palliative care in care homes, and that's just starting now. So we don't have anything any news that we can share about that progress with that partnership. But that's a watch this space, because I think that will be some really exciting work over the next year in that area. And then finally, we just wanted to talk to you a little bit about the significant investment that NIHR have made around workforce partnerships. So NIHR, the Health Services and Health and Care Delivery Services Programme, have funded 5 workforce partnerships following these exact research practice partnership models that I've just been describing. And they are 5 million per partnership. And at King's, we are lucky enough to be involved in 2. One which we are leading, which is focused on the social care workforce, co-led with the University of Leeds, and one that we are co-applicants on, which is all around workforce wellbeing and cuts across the health and social care workforce. So just to give you, and again, I can put the links in the Q&A in a moment, but just to give you a little bit of insight into what we're doing there and how that really links with the Better Health and Care Futures programme. So the Care Work Partnership, which focuses on social care workforce, which is led by myself and Karen Spilsbury at the University of Leeds, that particular partnership focuses on fostering a more effective and well-supported social care workforce, and that will focus on themes including workforce wellbeing, labour supply, demand and markets, data and technology, and innovation in work conditions and organisation. And it starts with priority setting exercises around those themes, both with the social care workforce and the sector as a whole, including decision makers such as policy makers, but also with people with lived experience of social care. So over the first 18 months, we're going to be designing some really exciting projects around those themes that will hopefully be taken forwards in years 3 to 5 to really make a step change in terms of working with the sector for the sector to deliver research that matters. The second partnership, which Annette is a co-applicant on, is led by Kath Taylor and Jill Mabon. And this work focuses on workforce wellbeing, but really builds on the work that that team have already undertaken around sort of care under pressure. So specifically, the aim of that workforce partnership is to try and move away from an emphasis on just the usual kind of resilience, you know, how can we increase resilience in the workforce, or what can we offer to people after a kind of crisis around well-being or mental health, but actually starting to test solutions that can improve staff well-being and create a more healthy workforce and workplace. There's some really exciting projects just starting that will be running over the next 5 years from King's. So just to draw to a conclusion and allow a bit of time for discussion, we believe that these partnerships really will make a step change in terms of making research more credible, context sensitive and implementable. And I think the real key message that we'd like you to take away is that this is about research with and for the sector rather than just to them. Over to you, Annette.
Thank you. So that's all we want to say. Hopefully we've left plenty of time for discussion, but please do get in touch with Anne-Marie or I directly. Have a look on our website, and yes, really looking forward to engaging more in the future.
Great. Thank you very much indeed for that. And I've been scanning through the Q&A questions. Hopefully people now are able to turn on their cameras and unmute themselves. I can see a magic thing. So please feel free and please do, if you're able, to turn your camera on, because that would be very helpful. There's an interesting question from Helena Habti Asres, and Helena, if you're there, if you're able to put your camera on, and you might want to just ask that question about the data sources. Where's your question? Here it is. Particularly data sources from the Department of Work and Pensions. Thank you. Helena, do you want to bring that question in? And Annette and Anne-Marie, you might be better placed than me to answer it.
Thank you, Irene, and thanks for great presentation and insight into better health. So my question is really to try and understand. So my background, I'm a nurse and I'm a clinical academic nurse in the Royal Free and a researcher at King's College. So my research is around big data. So I wanted to be able to understand what data sets are available for Department of Health to be able to link some of my health question, which will have implication in terms of people's health and well-being, as well as benefits. And if you intervene, say, in treating someone's depression, whether or not you kind of help them to move in terms of securing jobs and things like that. And I just wonder whether there is any routine database that's available from Department of Work and Pension for researchers. Thank you.
So most of the work we do with the Policy Research Unit is using the NHS employment record, and there's a surprising amount of data on that, and that's been very useful for most of the work we do. we're currently looking at a separate data set which looks at sickness absences across NHS trusts. So that's another big and useful data set which allows you to look at kind of, for example, types of trust and their sickness absence, the geographical spread, types of group within the workforce and things like that. So it's much more difficult, as Anne-Marie was saying, in the social care side of things. So for example, we've got a piece of work at the moment where we've been looking at whether staff from social care are being kind of drawn into the NHS, and whether that's something that the Prime Minister's concerned about. And it's really very difficult for us to study. So our team at the Institute for Fiscal Studies have been trying, and they just don't think at the moment there's the data there to do that work.
Thank you.
Just to add, I've put a link in the chat to the DWP statistics and resources. There may be something useful there, but I suspect the challenge that we'll have is around linkage.
Thank you. That's really helpful. I can't see very much else. I can see Anne-Marie's link. It's actually in the Q&As, so go to the Q&As for it. I can't see many other questions. There's a couple about, so the recording will be available afterwards, so everybody's very happy, very welcome to have a look at that. But perhaps people would like to put up their hands and ask questions. And as a very interesting question from Victoria Clement. Victoria, do you just want to come in and raise that question as we have time? You're asking, and I agree with you, it's hugely important, unpaid or lay carers and family carers, absolutely agree with you about that, and we are working on that. Victoria, if you're there, do you want to just put on your camera and just say what you're thinking of? Yeah, brilliant, thank you.
Yeah, no, I was just thinking, obviously, lay carers, family carers are really important. We don't always know who exactly these people are, you know, and they might be doing quite a lot of work in the background. Obviously, lots of your work is involved in social care, you know, with the rest of the workforce. You know, how are you able to access that group? What are you doing? You know, what challenges have you faced?
Can I start, and then I'll hand over to Annette and Anne-Marie, if I may. And Victoria, feel free to leave your camera on. I'm really going to encourage everybody, if they can, to turn their cameras on, because it's just so nice for us now to be able to see people, even when we're responding, if you don't mind, and if you're able to, of course. So just on informal carers, I mean, I showed you the figures. There's a massive issue around supporting informal carers, and one of the other things that is often said and is in the literature about carers is that one is that the label is not always ideal. What label do you use for unpaid carers? And I'll use the word unpaid carers because that's what Carers UK tend to use, but you can use lay and you can use informal and so on. The issue for unpaid carers is that often they don't self-identify as carers, because they do it because they're a family member. They do it because of love. They do it because they really care about the person and almost sometimes see it as a duty. And then the second issue is that, you know, they often, particularly at crisis times, can end up excluded from the health system, certainly, which I know better about. And that was particularly acutely seen, for example, during COVID, when during COVID, you know, people who had been looking after their relatives for ages and even looking after them in nursing homes and care homes alongside the staff were suddenly turned into visitors and were no longer allowed to enter or be with the person. And that was very hurtful for them as well, as things that we've heard. We have a project at the moment trying to look at ways to empower and better support informal carers. We're focusing on different areas. The work that I'm involved in particular is about carers of people who have serious lung conditions and the symptom of breathlessness. And we're very interested in how we can work with carers. There's quite a lot of different interventions and training packages out there, but they're all a bit patchworky in little local areas, and they're very difficult for people to access. So we're really interested in how we can kind of connect carers with the resources they want. So you're absolutely right. This has to be a key thing, and not for neglect. But let Annette and Anne-Marie come in, and obviously if anybody else has any thoughts or suggestions. But you make an excellent point, Victoria, and I'd be interested in your view on it as well, and what you're working on. Anne-Marie and Annette, anything from you on this?
Do you want me to come in? So actually, this is a really important topic, and we've done actually a lot of work on this. So until I moved to King's in September last year, and prior to that, I was at the University of Kent, and I led a programme of work which is around measuring the outcomes of social care. So what is the impact of social care on people drawing on carer support, but also on their family carers? And so we've spent quite a lot of time talking to family carers as part of that programme of work, and understanding the impact that social care services have on their quality of life. So you can imagine the kind of things that came out. So when services come in, either to support them or to support the person they're caring for, it gives them back, some time for themselves. It improves their sense of control. It enables them time to be meeting their own basic needs. And we developed an outcome measure that specifically looks at that. And I can put a link to that work in the chat if it's interesting to you. And the reason that that's important, we talk about measurement, but the reason that's important is because when we're looking at interventions that might help carers, we need to be able to assess whether they're cost effective and whether they really make a difference to people's lives. And to do that, you need measures that are sensitive to that, and that can help us understand the ways that these different interventions are making a difference. So although a lot of that work has been around measurements, I can also put some links in the chat to examples of how we've applied it, to better understand people's needs. So yeah, hopefully that's helpful.
Thank you, Anne-Marie. So I can see Jenny's got her hand up. So Jenny, I'm going to bring you in just a tick. There's two really interesting questions in the chat, which I'd like us all to pick up. One is from Laura Spence about involving local businesses in the work. I think that's a wonderful idea, and we'd love to work on this. And one from Lorna Fraser about focus on children's social care, because the data is even worse for children's social care. While you're thinking about the answers to those here, let's just hear quickly from Jenny Shand, as you had your hand up, and then we'll hear those, because we've only got about 5 minutes left now.
Thank you, Irene. I'll be really brief. It was just to say to Victoria, I think we very much see that partnership with carers as part of the care force. And I think what we've been reflecting on given the complexities of carers identifying in that role, what we have seen in some research that's been done to date is an appetite to have some structured learning and opportunities to be upskilled in their role as carers. And so we are thinking about that in terms of that extension. So just wanted to extend on some of the conversation on carers, but really interesting topic, and happy to talk further on that if helpful.
Great, thank you.
Just on, I think it's a really important point on children and families in social care. So we have a group in our unit who work on children and families, and it's very noticeable how much less resource there is to do research, how much less capacity there is in the system to help people grow research capacity, as we've had, particularly in healthcare research. So everything's starting from a much lower baseline in terms of investment and capacity. On the business side, Laura, I mean, it's going to be great, I think, to connect, having you at King's. It's going to be great to connect with your work. And we're always very mindful with the social care sector that it is a sector where business plays the predominant role in provision. And so it's not quite the same dynamic of conversation as we might have in healthcare, where actually we have to work, when we work very closely with providers who are kind of often small to medium-sized businesses providing social care.
Fantastic, thank you. Right, I think I can see something else. There's a few more things coming into the chat. We've got 3 minutes left, so we're nearly there, but if there's a burning, I'd love to hear any comment that somebody has or something. Yes, Claire, go for it, please.
I was just typing in case there was no time. As inequalities and inequities is a big theme of this. I was just wondering, perhaps specifically with Anne-Marie and Annette, you mentioned a panel for workforce, but also I think for service users. And I wondered if you have any insights or challenges that you've had to recruit people from diverse backgrounds. But just in general, perhaps it's for another webinar, how this theme is going to try and improve things for people that can't, maybe just don't have the same access and opportunities and have been marginalised in the past. Thank you.
Certainly, we found bringing intentionality to our recruitment. So we have recruited, we've just refreshed our panel of lived experience supporters. And with our workforce panel, we made it very clear in the process that we were keen to have a diverse representation. And then we made sure we were thinking about that in the recruitment process. So we did formal interviews, so we had an opportunity to really meet and talk with people about the work we did and what they were bringing to it. And so that's felt really important, and it's a really important part of the NHR drive for more research inclusion, that we are really thinking about it right from the start of our work and putting real effort into it, because otherwise it's very easy to end up with it sort of becoming a secondary issue when it actually is central to the work we do.
Fantastic. Well, look, thank you all for coming. We're aiming to do these webinars once a month at this time on the first Thursday of the month. They'll just be an hour long. You're very welcome to join us. I can't promise you tea and coffee, but I can promise you an interesting debate. We'll be advertising the next webinar soon, but thank you so much for joining us and for the interesting comments and suggestions. We'd love to get feedback. I'm not sure we've got a request for feedback for this one yet, Abby, if we have, but we will be including little questionnaires to you just on the sort of content, and also any suggestions for topics that you'd like us to consider. That would be great. But thank you so much for joining us, and special thanks as well to Anne-Marie and Annette for presenting, and big thanks to Abby, who's done all the kind of organisation of this behind the scenes, and also to Honor, who's the manager of the Better Health and Care Hub. Thank you all.
Thanks, everyone. Bye.
Bye.